Now, we're going to talk about clinical trials and some of the new data in hypertension that I think are going to change the way in which we treat our patients and in all likelihood make it somewhat more of an aggressive process than perhaps has been the case up till now. This is a trial that is perhaps the best known or the most commonly quoted of the hypertension trials. And I like to point out that it was actually published in 1991. It's 25 years since it was completed. And if you think that it probably was 5 or 6 years before then, when they actually started the work and conducted the trial, this is really work that's a good 30 years old. And yet, it has been the foundation of the recommendations for the JNC reports on hypertension from the early 90s all the way through to 2014. An amazingly impactful study. And it's a very simple story, really. They took older people, who had to be over the age of 60, with predominant systolic hypertension, and asked the question, should these people be treated? Very simple question, and it was a placebo-controlled trial. You would get chlorthalidone, you're randomized to chlorthalidone on the active arm or placebo. The study went ahead slowly but steadily. It took a long time to recruit these patients, and they achieved a systolic blood pressure of 155 in the placebo group and 143 in the actively treated group. And that was associated with a very nice 36% reduction in stroke and a similar 36% reduction in myocardial infarction. So a very positive outcome, very exciting. And most people looked at these data and said, well, this has taught us something. And one of the things is that we ought to get people's blood pressure down as close as possible to 143. And so the JNC 5, 6, and 7 reports in the 1990s and the early part of this century all suggested that 140 would be a good target for treating hypertension based very much on this study. And then JNC 8 came along. And this is the headline from their report, Evidence-Based Guideline. And let me emphasize, it was the same evidence as before, the same evidence that 3 previous JNCs had looked at. And they went on to make a very clear recommendation based on the study we just looked at, which was in the general population, age 60 or older, just as I told you, they now say you should initiate treatment in people when the pressure is more than 150 and reduce it to less than 150. So now they've looked at the same data, and it's fascinating. They spent 6 to 9 months of weekly conferences, this large group of experts, hours and hours every week, with a budget of $15 million that was spent on vendors to help them analyze the data, and they came up with a recommendation of 150 being good enough as a target in people aged 60 or older. Not a particularly popular recommendation because 5 of the 14 members of that committee, in an unprecedented move, wrote a minority opinion and wrote an article in another journal in the archives strongly criticizing this recommendation and saying, why didn't we stick to 140? As it turned out, even they were on the conservative side. Meanwhile, other studies had looked at older people. And there's a lot of emphasis on older people because those are the people sitting in our waiting rooms with hypertension and at greatest risk of relatively imminent outcomes. The HIVET study looked at people aged 80 or above, really quite a dramatic attempt to look at older people. You had to be relatively ambulatory. You had to be able to come to the doctor's offices. Average age at the start of the study was about 84. The average age during the course of the study was closer to 87. More women than men, as you'd expect in an older cohort. And they started with a similar blood pressure to the HOPE trial, and the study went on fairly slowly, again, hard to find the right patients, but they finished up with blood pressures very similar to what we saw in HOPE, 143 in the people getting active treatment with, they got a thiazide diuretic, indapamide, or thiazide-like diuretic, plus an ACE inhibitor, and again, placebo. And the results, very convincing that there was a benefit in treating these older people down to around 140. The mortality data, 21% reduction, actually caused the study to be ended early for ethical reasons. You can't keep a study going when one of your treatment arms is having an excess of mortality. But everything was improved, including heart failure quite dramatically by better than 60%. But we'll talk more about that in a moment. Here is more data, but now in a sense post hoc data, which most of our data are in hypertension, from a trial that was not designed originally to answer the question, how low should we go when we treat blood pressure? For that matter, neither was the HOPE trial. But this time around, we are looking at a big trial called VALUE, where we asked investigators to get the blood pressures down to less than 140 systolic. And so we were entitled to ask the question, after 6 months of treatment, when all the titrations had been done, and now we moved forward from there, did it really make a difference to get to less than 140? And the answer is, you bet it did. It made a huge difference. Stroke was reduced by better than 40%. Myocardial infarction was reduced. Death was reduced by 21%, exactly the same as HIVET. And there's a continuing repetition of these kinds of results in all the trials. Heart failure reduced again quite dramatically by better than 30%. So no argument. Getting the pressure down to less than 140 seemed to be very good. And by the way, the age of these patients, just like the HOPE study, above 60, the average was somewhere in the late 60s. Here is a study that just got published. In fact, it's not yet in print, but it's online, published, will be published in The Lancet. This is the Clarify Registry, a very authoritative study looking at people who have coronary disease, established clinical coronary disease, asking the question, what is the best blood pressure for them as time goes by? And no big surprise, and particularly not for my friend Clive Rosendorf, who's sitting here today, and a very distinguished member of the faculty here at Mount Sinai, who has been responsible working with the American Heart and American College in putting out the guidelines for hypertension treatment in people with coronary disease. We see that the optimal outcome is roughly in the less than 130 range, between 120 and 129, and that is the reference. And now when we look at other levels of blood pressure with our primary outcome of cardiovascular death or non-fatal MI or stroke, the usual triple outcome, we see that going up to less than 140 doesn't really make things much worse. But going to above 140, up to 150, clearly you see a deterioration in outcomes, and more than 150, it's pretty bad. Going to less than 120 also does not seem to provide further benefit. If anything, we move in the wrong direction. And the numbers are big enough for us to feel that's a reasonably strong discovery, a reasonably important finding. So again, we're left thinking somewhere around 130, 140 looks good. Let's not get above 140, and let's be a little bit cautious about less than 120. Here is another trial that just came out this year. I shouldn't call it a trial, it's a meta-analysis by Etihad and company from the George Institute, which is an international outcomes epidemiology kind of institute, headquartered at Oxford University, but with branches in other countries, including Australia. And they looked at 123 studies including some that were not hypertension studies. The only criterion for a study in this meta-analysis, also published in The Lancet to a lot of fanfare, the criterion was that patients would get drugs that could be regarded as blood pressure medicines, and blood pressure was measured. That was it. It didn't have to be hypertension. Could have been post-MI, could have been any sort of indication you'd like to think of. As long as you got an ACE inhibitor or any kind of blood pressure medicine, you were in this meta-analysis. And it was a biggie. They had 613,000 patients included, and they found, regardless of where you started with your blood pressure, a 10 millimeter of mercury reduction in systolic blood pressure resulted in a very nice reduction in major cardiovascular events, about 20%, coronary heart disease, again, highly significant, stroke, 27% reduction, very significant, and heart failure, once again, close to a 30% benefit. So what they're saying is, as long as you're taking blood pressure medicines, it doesn't even matter where your blood pressure is. It can even be less than 130 when you start all of this. You seem to do better. Now, it is, like some of these large meta-analyses, a mishmash of different patients, different countries, different things going on. You have to be really cautious with a meta-analysis like this, but no question it has had a big impact on people's thinking. Here is one of the classic studies, because it was an a priori attempt to really ask the question, what is the best blood pressure? Let's not borrow from other trials. Let's ask the question directly. And in Accord, they studied patients with diabetes. It was going to be a big diabetes trial, and it was, and they were looking at other things beyond blood pressure in this big trial. But nevertheless, a very authoritative study asking the question in these diabetic patients, should we shoot for 140 or just less than 140, which is what most people had believed, or should we be super aggressive and shoot for less than 120? Well done study, because they finished up in the standard group at about 134, and in the intensive group, the less than 120 group, they actually got down to 119. A beautiful blood pressure separation between the two groups, and the results were somewhat equivocal. This is the primary outcome, which is, again, the classic MACE, the non-fatal MI and stroke and cardiovascular death, reduced by about 10%. And so people looked at this and said, oh, how disappointing. This is a bit discouraging. No advantage or no benefit in pushing treatment in diabetic patients any lower than just getting down to below 140. Except for one of the parts of the primary outcome, stroke, there was a 40% and highly significant reduction. So it's one of these glass half full, glass half empty situations. Some people would look at this and say, since stroke is probably the most feared of all the outcomes of hypertension, maybe we could think about being a bit more aggressive. It's not necessarily, though, a good idea. And this is, these are data from the ACCOMPLISH trial published earlier this year, where we had enough patients to look at different levels of achieved blood pressure and subdivide the patients into diabetes and people who did not have diabetes. And it's interesting, in the people who don't have diabetes, you can go from above 140 to less than 140, less than 130, less than 120, and there's a continuing improvement, a continuing reduction in major events, stroke and other outcomes. But diabetes is not so simple. Everything looks good, and clearly a big benefit to get to less than 140. Getting to less than 130, no real difference. And as you go beyond that, there's actually the appearance of an increase in events once you get to less than 120. The same thing we saw in the coronary trial that I showed a moment ago. And when you look at the details of this, and I didn't want to show too many slides on this subject, it's all driven by myocardial infarction. MI and fatal coronary events is what drives this increase once you get below 120. Stroke does fine in the diabetics, but coronary events do not do well at less than 120 in people with diabetes. And I'll skip this slide. It's another meta-analysis that doesn't teach us that much. So let me get to the granddaddy of them all, the SPRINT trial, which was just like the ACCORD study we looked at, people randomized to less than 140 or less than 120, but now in non-diabetic patients. They excluded people with diabetes, thinking that they'd already been studied pretty well in the ACCORD trial. Both of those studies, by the way, ACCORD and SPRINT, done by the NIH. And you can see they have people in intensive treatment less than 120, and people with so-called standard treatment less than 140. And again, just as in the ACCORD trial, very nice separation of the blood pressures. The people less than 140 finish up around 136, 135, it varied over time. And the people in the intensive group around 121. They didn't quite get under 120. On average, these guys in the standard treatment were getting 2 drugs, varied of course, but the average was 2, and in the intensive group, about 3 drugs. And so it was done very simply, done very nicely. It was obviously not a blinded trial because you had to know whether a patient was standard or intensive, so you could titrate the treatments accordingly. The result was spectacular. And we all saw it in the New York Times and the Wall Street Journal and heard it on the evening news. Getting people down, they said, to less than 120 resulted in a 25% reduction in the primary outcome. And it was a composite outcome, which I'll now show you on the next slide, made up of several items listed under the primary outcome. So all of these things go into the primary outcome reduced by 25%. But kind of funny if you look at the individual components of this. MI is reduced by about 17%, which is typical. If you could remember some of my earlier slides, we also saw MI reduced not as much as some of the other outcomes. A bit startling, stroke only reduced by about 11%. Is this a chance finding, or are we being told something here? We're not clear, but this was a bit surprising. The big winner, in a sense, was heart failure, reduced by about 38%, and I'm going to come back to that in a moment, and cardiovascular death. And in a way, it's the cardiovascular death that drives things and should be the most important, because I think we all know, those of us who have done clinical trials, there's always some debate about some of these other diagnoses. It's not always easy to tell why someone has had an event and is it truly what the investigator thought it was. But death is pretty unequivocal, and it was reduced by about 40%. So no question, you have to look at this and say, intensive treatment for me, this is where we should be going. And by the way, these were patients, average age 68. Now, there was a pre-specified sub-analysis, or several actually subgroup analyses, but the one I wanted to draw attention to are people aged less than or more than 75. And you can see the people aged more than 75, and by the way, their average age was exactly 80. About 30% of patients in the trial were over the age of 75. Average was about 80. And if anything, they do a bit better. It's not statistically significant. This is not a heterogeneous outcome. But nevertheless, they have a very nice 33% reduction in the major events. Interesting. So suddenly, older people, the people who used to think, be careful, be cautious, don't overdo it, if anything, do at least as well as younger people. Clearly, we're getting to a point, no age limits on treating hypertension. Here are the outcomes in that particular group. And you can see that they are very similar to the total group. This is just the people aged more than 75. Everything looking good. Again, not too convincing in any one outcome, though a little bit more realistic. Now we get close to a 30% effect on stroke, but the numbers are small. Interestingly, cardiovascular mortality is not quite significant because the numbers are small. All-cause mortality is fascinating because the numbers are big, and if you subtract cardiovascular mortality from all-cause mortality and have so-called non-cardiovascular mortality, that is significant. And I actually spoke to the SPRINT investigators and said, how do you explain that? And they said, and when you think about it, it's very logical, it's very hard to know why people have died. And they suspect that many people labeled as non-cardiovascular mortality, in fact, did have cardiovascular mortality, but the deaths were not witnessed, they did not take place in an institution, and so rather than speculate, they were put into this box. But I suspect many of these people called non-cardiovascular really belong in the cardiovascular group. Very strong result. Now, what about the blood pressures? Less than 120 seem to be better than less than 140, but there is a big but. And let me just take a moment to explain this. Blood pressures in SPRINT were not measured in the usual way. What happened was they put an automated device, an Omron device, which I'm sure many of you have in your offices, and heck, many of you probably have in your homes because it's the most popular device that's sold to patients. An automated device was used, and after the cuff was placed on the patient's arm, all medical personnel, doctors, nurses, whoever else, were told to leave the room, and the patient was left in splendid isolation, free from any white coat effect, and sat there quietly for 5 minutes until the device automatically started measuring blood pressures. And they did 3 blood pressures at 1-minute intervals, averaged them out, and that became the official unobserved blood pressure. And blood pressures by this method, we believe, based on a number of other trials, are about 7 to 10 millimeters of mercury lower than the conventional pressure that you or I would measure in our patients in our offices. So, getting down to it, the achieved systolic blood pressure of 121 reported in the intensive group in SPRINT corresponds to roughly 130 millimeters of mercury by usual clinical methods. So the take-home from SPRINT is not less than 120, it's less than 130. They made an error in their trial design. They did this clever experiment, measuring blood pressure this unusual way, but they didn't control their experiment. They should have done conventional office readings as well as the unobserved readings to really teach us the benefits or otherwise of doing this special method. But nevertheless, I think we feel comfortable, and I think most of the guidelines are going to say that less than 130 should now be the usual target for non-diabetic patients. Interesting, isn't it? Even the best designed trials always leave you wondering about some critical element. In Europe, they have a totally different interpretation of SPRINT. They asked the question, could it not just be the fact that the blood pressure was lower in the intensive group? Couldn't it just simply be a matter of more good drugs independent of the lower blood pressure? And this certainly has been shown in a number of clinical trials where you had somewhat similar blood pressures, never exactly the same. It's always a bit of a juggling act to figure out exactly what's going on. But these are trials where there were differences between drugs or between treatment regimens that seemed to be important in terms of preventing cardiovascular outcomes and could not really be explained by blood pressure. So look at SPRINT again. And this is really quite fascinating. First of all, let's look at the intensive treatment and the standard treatment group. And let's jump down here for a moment. Heart failure events. Remember, I pointed out they were quite dramatic. That was a better than 60% relative reduction. Very strong finding. But when you look at it, there were 62 events in the intensive treatment group, 100 in the standard group, 38 different. Now look at the drugs. Thiazide-like agents, including the powerful chlorthalidone, which was used quite commonly. There were 1,000 more people in the intensive treatment group getting a diuretic, and 1,000 more people getting blockers of the renin-angiotensin system, and more people getting beta blockers and spironolactone. So the big question is, could 38 fewer heart failure events be explained by 1,000 more people getting diuretics, 1,000 getting renin blockers, and all the other treatments? Is it just the fact that you're getting more drugs that are good at treating and masking heart failure? Think about it, right? These are the optimal treatments for hiding the symptoms of heart failure, right? The diuretic gets the fluid out of your lungs, you're not so short of breath, and the RAS blockers, of course, decrease the afterload. So you really wonder whether it was a real finding in terms of blood pressure, or whether it just reflected the fact that these patients were already getting treatment for their heart failure, particularly in the intensive group. And you can ask the same question about the cardiovascular mortality. Now, these numbers may not be strictly accurate because, as I already explained, there might have been more cardiovascular events that were just not accurately diagnosed. But again, you're looking at now, throw in the calcium channel blockers, also 1,000 more patients getting amlodipine and things like that, which we also know are protective against cardiovascular mortality. And is this a blood pressure benefit, or is it, again, just due to more medicines? Adverse events of this more intensive treatment, not bad. And in fact, some hypotension, some deterioration in renal function, which may have been reversible. I mean, that's an important question. As you know, a creatinine often goes up with active hypertension treatment. When you stop the treatment, the creatinine improves again. So we're not sure how important it is. It is important, but maybe not as bad as some people have made out. And in any case, when you've been saving that many lives, for whatever reason, you are going to be much more forgiving of some symptomatic side effects. Just to finish off the other study that I was asked to mention, HOPE-3, that was published and presented earlier this year. All these studies seem to have come out in the last 12 months or so at the ACC meetings by Salim Yusuf. It was a large, simple trial done across several countries, and it was basically being done to see if you could just take people over a certain age, men more than 55, women more than 65, and give everybody blood pressure medicines. Would that save events? Would that be protective? But they were not terribly high risk. They excluded anybody who'd had any sort of a cardiovascular event in the past. So they were pretty healthy people, though if they had a history of smoking or family history of cardiovascular disease or reduction in the HDL and so forth, that got them into the trial. But it was a much lower risk group than we see in the other hypertension studies. And the result was complete zilch. They compared placebo with active treatment, an ARB and a diuretic. It's a bit strange because in clinical trials with this treatment combination, they all got the same drug, they all got the same medication. It lowers blood pressure on average by about 15/10. In this trial, it only lowered blood pressure by 6/3, which makes me think a lot of patients were not taking it at all, or who knows what was going on. But in any case, it was a negative result, although they had pre-specified that they would look at different baseline levels of blood pressure. So for people more than 140 at baseline, there was a nice benefit in terms of this combined outcome of cardiovascular death, MI, stroke, and so forth. People between 130 and 140, pretty much neutral, and a little bit of a trend for people who started out at less than 130 doing badly. Not significant, and it's, again, very difficult to explain. Again, let me remind you of the Etihad meta-analysis I showed earlier, where they showed that starting treatment like this in people less than 130 was beneficial, significantly beneficial. It's pretty hard to know what was going on in HOPE-3, and I think we need to do a lot of thinking about that, because it was not a diabetic cohort. And just one last thing before I finish. Every study that I've talked about, and I've listed them all here and others that I haven't even talked about. These are in the last several years. I haven't gone back too far in history, but I would say for the last 20, 30 years, the major clinical trials in hypertension. And this is the average age at baseline. It's 67. So the average age at the time of events is about 70. So it's not a young group. Now, it's a very relevant group, because you don't need me to tell you, when you look in your waiting rooms, most people are around 70. In fact, I would say 3/4 of the people, or even more than that, in anyone's waiting room are going to be in the 60s, 70s, and 80s. But it does remind us that we know nothing about hypertension in people aged less than 55. If you're evidence-based, you really are totally on your own when a younger person, someone under the age of 55, comes in with high blood pressure. And it's scary because more and more studies are showing that even young people with elevated blood pressure are already showing signs of arterial stiffness, left ventricular hypertrophy, microalbuminuria, the signs and findings of impending vascular disease. What do we do about them? What sort of blood pressure targets for them? This is a huge frontier, and I know Dr. Lloyd Jones, who's going to be talking in a moment, had a very important study with his colleagues looking at outcomes of hypertension in young people, and it's really quite important, and it's a shame that we don't know more about what to do. When you see these younger patients, you're left guessing. So these are the conclusions about blood pressure targets. For non-diabetic patients at medium to high risk, which is most of the trials I talked about, except the diabetic trials, then it's probably very reasonable to say that less than 130, just like in SPRINT, is a good target. I'm totally on board with that. I don't think there's going to be too much fighting over that. For diabetic patients, less than 140 is probably good enough. Some people would say we could push down a little closer to 130, particularly if there's signs of albuminuria, and I'm not going to get into the renal studies and the debates of the nephrologists. But in general, diabetic patients seem to be more susceptible to the so-called J-curve effect, the adverse outcomes of pushing the blood pressure too low. So we shouldn't be too glib about pushing diabetic patients to less than 130 without watching them very closely. And maybe from HOPE-3, you could say maybe for really low-risk people, less than 140 may be good enough. We'll see. These are early days, and we're still interpreting the results of these trials, but at least I think we're getting closer to having enough evidence to at least put out a much better set of guidelines that the ACC and the AHA are going to be putting out in February of next year, that I think will be much more useful for all of us who practice medicine. Thank you very much for listening.